Good evening, everybody, and welcome to tonight's webinar on Adult Asthma Management, What's New? Sydney North Health Network wishes to acknowledge Australia's Aboriginal peoples, the traditional custodians of the land on which we meet and work. We pay our respects and recognise their continued connection to land, water and community, and honour their ancestors, elders, past, present and emerging. My name's Sandra Collins and I'm part of the practice support team at Sydney North Health Network. The usual housekeeping, please use the Q&A box if you wish to ask questions of the presenter. We will be stopping at various times to do that. If you use the chat box, the questions may not be monitored. So I'll do my best to cover both, but please use the Q&A box with preference. The meeting will be recorded. And as you log out tonight, you will see a link for an evaluation, and it will also be sent to you tomorrow. Please do complete the evaluation, as your feedback is very valuable to us, particularly for tailoring further future education events. As always, a mention of health pathways. I'm sure many of you are familiar with this now, and I hope you've all had a chance to have a look at it and use it. There are benefits to the patients, the clinicians, and the local health district, particularly with regard to hospital avoidance. The username, as you can see up here, is Health Pathways, and the password is Gateway. These are the pathways that are relevant for asthma, and as you can see at the top left, there are 3 new pathways: acute asthma in adults, non-acute asthma in adults, and asthma COPD overlap, which are then added to the suite or existing suite of adult respiratory pathways. So I urge you to log in and have a look. You can put the icon on your desktop. You can install it on your mobile phone. And there is a feedback button on every page. If you see something you feel needs comment, please click on the feedback button. It will generate an email where you can write your comments, and then that will be sent directly to the Health Pathways team. So without further ado, I'd like to welcome our speaker, Rhona MacDonald. Rhona is a Respiratory Nurse Practitioner for Westmoreton Hospital and Health Service. She has a Master of Nursing in Chronic Disease Management and completed several postgraduate courses in asthma and respiratory management and COPD care. She has been a nurse practitioner for 11 years and has worked with respiratory patients since 1995. Thank you, Rhona, very much for doing this presentation tonight, and I'll hand over to you.
Hello, everybody. I'm just sharing my screen. Hang on 2 seconds. Go. So tonight we're going to speak about adult asthma and what's new from the National Asthma Council. There's a series of talks for the National Asthma Council. Some of them are on paediatric asthma, some of them are on adult asthma, asthma and COPD overlap. There's a few. I'm not sure if anybody's booked in for other ones, so I don't need to do that. So today what we're going to cover, the topics we're going to cover: Australian Asthma Handbook. So that is the guidelines for asthma in Australia and GP land. Asthma pathophysiology and triggers, how you diagnose asthma, management of asthma, adolescents and asthma. I'm going to talk about that a little bit. What a written action plan is, and acute medical management of asthma in primary care, and some about the asthma and COVID-19 guidelines, which will be interesting for you guys. So these are the learning objectives. I'll not read them out. I'll let you have a quick read at them. So we're going to go through some medication management, that kind of thing today. All right, so when you get a chance after this talk, probably not tonight because you probably want to go to bed, but this is the guidelines for asthma in Australia and GP practice or in primary care. So the Australian Asthma Handbook, and that is the website address there. And if you go on there, there's lots, you can actually just search for things. So if you wanted to know about, say, severe asthma, what's that? Or medication management, you just type it into that little search button there and it will come up with the area that you want to look at. And it comes up with all the research behind where we got all this information from. It's updated regularly. If there's any new things coming out, we'll update this. So we're on version 2.1 at the moment. And there's also a website for the National Asthma Council, and that's the website address. And on there you can find things out about COVID-19, about your patients with COVID-19. You'll find all the guidelines for spirometry with COVID-19, things about, there's medications like as an inhaler technique, little videos on there. So there's lots of things, and there's things that you can download and print for your patients if you want to. The National Asthma Council is in Melbourne, so most of them are working from home at the moment. So if you need like brochures and whatnot, you have to download them and print them yourself now, just because they're not in the office, so they'll not be posting anything out to you. So we're going to have a little bit of stats on asthma in Australia. So there's about 2.7 million Australians have asthma, so that's about 10-11% of the general population. So 1 in 9 Australians, which is quite high by international standards. But if you look, most of the places like United States, Britain, Australia, they are quite high by international standards. So there might be a bit of bias there in that we're reporting it more than other countries. But since 2001, there's been a decline in children and young adults being diagnosed with asthma. But over 35 years of age, it's quite stable. Now, when you look at children, it's more common in boys than it is in girls, so up to adolescence. And then it swaps over and it stays the same for the rest of their life. There's more women than men have asthma. In 2019, 421 people died from asthma, which is very sad. And these are usually preventable deaths. Nobody really should die of asthma. 2018, 389, so it's not going down. It goes up and down a little bit over the years. And interestingly, 50% of people with asthma over 75 have not been diagnosed by a doctor with asthma. They might have asthma, but not been diagnosed properly. Might be diagnosed with the wrong thing. Reports around the world show that 25 to 35% of people with a diagnosis of asthma in primary care might not even have asthma. We'll go through differential diagnosis later on. So what is asthma? Asthma is a chronic lung condition, and a lot of your patients think it's something that comes and goes and they don't need to worry about it in between, and that's why they just live on Ventolin. But it's actually a chronic lung condition, and it can be controlled but not cured. We can't get rid of it. Some children grow out of it, but they might have it later in life again. In clinical practice, though, it is defined by the presence of both the following. So excessive variation in lung function, and you can see that on like spirometry. And variable respiratory symptoms. So they might be unwell for a couple of weeks when they have a virus, and then they're okay for a couple of months, and then they go to their aunties who've got a cat and they get unwell again. They might not have symptoms every single day. So asthma is in the small airway, so in your bronchioles. A normal bronchiole would look like the little bronchiole, the normal airway on your left. So inside is inside of your mouth. You have little goblet cells, and on the outside there's little smooth muscles, which are quite relaxed. And at the bottom of all these tiny little bronchioles, there's alveoli sacs. So when we have asthma, what happens is something in the air is triggering off your body's response to say, there's something nasty coming into the airways. We need to close them down. So what it does is it gets the inside of your bronchiole to swell up. So it gets red and swollen, and it also produces more mucus from your goblet cells. And if it goes on for any length of time, you actually put down more goblet cells so that you can produce even more sputum, which is lovely, really. And then smooth muscle on the outside, that can tighten down. And that's why people feel their chest is tight. And then we get air trapped in the alveoli because the airways are too small for the air to come back out. So it's a constriction of the smooth muscles of the walls of the airway, but it's also inflammation of the lining of the airway. So that's important when we talk about medication, because Ventolin only deals with the constriction of the smooth muscles, does nothing for the inflammation. So characteristics of asthma is a chronic inflammation of the lining of the airways, the small airways, the bronchioles, sorry, and it's usually associated with airflow obstruction. It might be widespread, but that can change. It's often reversible, or either with just sitting down and resting, or with treatment as in Ventolin or Bricanil, something like that. The inflammation causes recurrent episodes of common symptoms, and the common symptoms are listed there: wheezing, breathlessness, cough, and chest tightness. Not everybody has all of those symptoms. So some people might just get breathlessness and a cough. Occasionally you'll just have a cough on its own, but that's very rare. That's called cough variant asthma, but that's quite rare. Not all asthmatics wheeze. So some of our really severe asthma patients, so I run a severe asthma clinic with a doctor up at our hospital, and some of our asthma patients never wheeze. They don't sound wheezy at all. Their airways are so tight that the air is just going in and out and not making the bronchioles shudder, which makes the wheeze. So triggers, lots of different triggers for asthma. I don't know if any of you have asthma, and it's different with every person. So you can't say that every asthma person is triggered by pollen count or cats or dogs, or everybody's different. It's very important to identify those triggers though, so that you can see if you can avoid some of them. Not all of them are avoidable, but that might improve their asthma control. So there's things that are unavoidable. You can't avoid exercise and laughter. Well, I don't know, I can avoid exercise quite well, but you're not supposed to avoid exercise or laughter. A lot of asthma patients will modify their lifestyle, like don't walk up the stairs, they go up in the lift instead of walking up the stairs, because they know that exercise triggers their asthma. But we want to try and get them as fit as possible, so we don't really want them avoiding exercise if possible. Things that we can manage, so triggers like respiratory tract infections, like the flu, we can try and manage by getting flu vaccine. There's certain medications really could trigger asthma that we want to avoid, aspirin and these other two cholinergic agents and anticholinesterases, I can never say that one, because they might trigger asthma. Other comorbid medical conditions, allergic rhinitis or hay fever, that's quite a common one that patients will have with asthma. And if that's out of control, quite often the goo will run down the back of the throat and trigger off their asthma. Obesity is quite a common one to make asthma worse, and it's not just really about carrying the extra weight, it's actually fat cells that trigger off asthma. Upper airway dysfunction, so vocal cord dysfunction and reflux can all make asthma worse. And there's changes in the air or psychological changes that can make asthma worse. So extreme emotion, so if they get really upset or their hormones change. So that's why boys have more asthma as children, and then at puberty it changes over. So that's the hormone changes in girls that's causing that. Pregnancy. Pregnancy is an interesting one. About a third of pregnant women with asthma will have improved asthma symptoms. A third will stay the same, and a third will get really bad. So these people are worth a watch while they're pregnant, just to make sure they're okay. Avoidable triggers, cigarette smoke, definitely avoidable. And it doesn't have to just be cigarettes, anything you smoke. And the other things that you can try and avoid a little bit are, if you're allergic to animals, try and avoid them. Cockroach poo, house dust mite poo, pollens, molds. So I quite often do a home visit to patients who have got severe asthma, just so I can check out the house, see how many cats they've got floating about, how much mold is on the ceiling. We get a lot of mold in Queensland. And that kind of gives us an idea of what's happening at home, because that's where they are most of the time. So irritants as well, you can try and avoid like cold, dry air. I thought it was hilarious when I moved here from Scotland that people would say, oh, when the cold air comes in the evening, my asthma gets worse. I'm thinking, wow, it never really gets that cold here. But I think it's the change in temperature. So it might be Queensland might be 26 during the day and then drop to 5 degrees at 5 o'clock at night. All of a sudden it's dropped like 20 degrees. And it's that change in temperature. Perfumes and sprays. So we speak to patients about trying to avoid walking through the big department store through the perfume department or putting perfume on themselves. Smoke of any kind, obviously, we can try and avoid that. Environmental pollution, they can try and avoid. Thunderstorms in spring and early summer. There is a talk about thunderstorm asthma, but those thunderstorms, the electricity in the air can break up pollens and make them smaller so that they get further down your airways. So that's why we try and stay indoors with the windows shut and have Ventolin handy when there's a storm coming. Certain medications like aspirins, non-steroidal like Brufen, all those kind of things. Beta blockers, you'd be surprised how many patients come to our clinic who've just had a heart attack and the cardiologist have put them on a beta blocker and now their asthma's out of control. It's funny that, because we're blocking their beta receptors and their Ventolin and their other medications not working properly. Bee products like royal jelly and echinacea. A lot of patients think because they're herbal remedies that they're not going to cause any problems, and they can really cause problems. Dietary triggers are quite uncommon, but they can be there. So it's usually chemicals or additives that cause the issue. A lot of people will say, oh yeah, if I drink too much milk, it's not really, I don't think that's probably an issue. It's more the chemicals and additives that are in things that are causing the problems. So adolescents, when we're talking about adolescents and guidelines, where do they fit in with diagnosis and management? So under 14, we use the children's guidelines, and we're not going to talk about the children's guidelines and management today. And around 14 to 16, depends on the size of the kid really, we go to the adult guidelines. Our clinic takes kids from the age 15, so from 14 up, so that would make sense. With adolescents, there's obviously a lot of things going on, rapid growth, they're emotionally and socially changing, they're at risk of mental health issues, and they're starting to try out our patients by risky behaviours and starting to smoke and not do any exercise and take drugs and drink. So these kind of issues can be challenging to get patients controlled with their asthma. So it can really get worse in adolescence, but also it can improve. Just depends on the child. Less than 1 in 5 Australian adults have a written action plan. When we go through action plans, you'll see that they can actually make a big difference to people's control of their asthma. And only 28% have discussed their asthma with a GP in the past 12 months. That to me sounds like they're not taking any preventer, because if they've not discussed their asthma and they're not getting any prescriptions. Adherence to preventer medication is very poor. They think they're invincible at that age. So when you're seeing adolescents in general practice, try and see them alone for part of the consult anyway. You need to maintain some confidentiality, especially if they start telling you they smoke or take drugs or anything. I had this is not an adolescence, I had a 7-year-old in Scotland, because I work near Glasgow, and he was in with his dad for his asthma review, and I just jokingly, because it was part of your assessment, said, so do you smoke? And his dad nudged him and said, well, tell her then. And he had started smoking age 7. So they're never too young, okay? You need to look at psychosocial issues that are affecting their asthma. They might not believe they've got asthma. It might be a cultural thing. Financial problems is a big one, especially with adolescents, because mum and dad are probably trying to get them to stand on their own 2 feet a little bit, get a little job, and they expect them to pay for their preventer, which could cost them $41 a month, which is a lot when you're not getting a lot. So you can refer on to appropriate services if required. When you're transitioning to adult care, you shouldn't just assume that they've got good self-management because they've been a child with asthma. It doesn't always work that way. Education, there's, I think this is in Sydney, a AAA peer-led education programme. So I had to go and look it up because we don't have it up here in Queensland. And the AAA programme is a programme set up where older adolescents, so older teenagers, 19, 18, will teach the younger teenagers about their asthma and why they need to take their preventer, that kind of thing. So they take it a little bit better from them, because they'll probably look up to those older adolescents, whereas we're just old grannies, so don't listen to her. So that's a good program, AAA, you should look that up. Always check their inhaler use, especially the reliever medication. So how much they're actually going through, how many puffers are they going through, and you'd be surprised how many Ventolin puffers people can go through in a week. And they really do need a written asthma action plan. So when we're looking at diagnosis of adult asthma, I might stop here for 2 seconds just to see if there's any questions so far.
There's nothing in the box, Rhona, at the moment.
Cool, thank you. Right, so diagnosis of, they've all gone to sleep, Sandra, that's what it is. Diagnosis of adult asthma. So when you're looking at the diagnosis for a person with asthma, you need to go through this little flow chart, really. You need a really good history. So you want to know when they get the symptoms, how often they happen, is it worse at night, first thing in the morning, or is it worse during the day when they move about? When does it happen, especially like kids, does it happen when they catch a virus, or does it happen when they go and visit auntie with a cat? You know, that kind of thing. You want to see what triggers it off, what is actually happening at home. And if you think, yeah, that sounds quite like asthma, you need to do a lung function test. So spirometry, pre and post bronchodilator. So remember, you need to withhold their bronchodilator and any other puffers that are on, depending on which one it is, how long you have to withhold it. And you're looking for an increase in their FEV1 of at least 200 mils and 12% from baseline. So you need them both. The problem with little old grannies is they have very small volumes. So a 12% increase might only be like, I don't know, 20 mils, you know, because it's only a little volume. So you have to be very careful with that. You might see a huge increase like 30%, and actually it's only 70 mils. It's not reversible airflow. It's not reversibility. Alrighty, so if you think the spirometry definitely shows asthma, there you go. You can start your treatment and review the response. Now, at any point in this, if you don't think the physical history and the physical exam and the history sounds like asthma, you're looking for an alternative diagnosis. Things that you would be looking for, like heart failure, or if they've got a cough, it might just be like reflux, that kind of thing. So if you've managed to diagnose their alternative diagnosis, there you go, that's you. You can come out of this little diagnostic square thing. But if not, you still don't know what it is, you might need to consider doing a bronchial provocation challenge. Now, that isn't done in general practice, that's done at a respiratory lab. So that's when we get people to breathe in mannitol. It's usually mannitol anyway, and watch how far their lung function drops. So kind of the opposite of spirometry pre and post, we're actually inducing an asthma attack in asthma patients. And if that confirms they've got asthma, there you go, you start your treatment and review your response. If you're still not in the wiser, then they need to be referred on to a respiratory physician to see. So we get a lot of referrals for chronic cough and things like that, so shortness of breath. We will, when we're doing diagnostic testing, if we've got the confirmation of spirometry, we'll start doing allergy testing to see what they're allergic to, IgE, full blood count, see what their eosinophils are. And if we might try a treatment trial, so we might try them on something and then bring them back and do spirometry again and see how we go. So when we're looking at history, we're looking for what symptoms they have: wheeze, chest tightness, shortness of breath, cough. When does it happen? What makes it worse? History of allergies. So people with asthma quite often have allergic rhinitis, or atopy just means allergies. Eczema. So basically allergic rhinitis and eczema are asthma on your skin and up your nose. So if they've got a family history of asthma or allergies, now we're talking first degree relatives, mum, dad, brothers, sisters, or children, but children I'm a little bit dubious about because that might come from the other parent. Identify triggers that make the symptoms worse. So a patient might tell you, when we have the cold westerly winds up here, their asthma gets worse, or when we take the kids to grannies and they've got cats, their asthma gets worse. So that's the kind of thing you would want to mark down. Smoking history, so all forms of smoking. E-cigarettes as well. So e-cigarettes have got all those flavourings in them that really aren't good for your lungs. And if they've had any exposure to cigarette smoke or their mum smoked when they were pregnant, that's quite important. Physical examination, so you're looking at their breathing, how they breathe. So if they're using their shoulders all the time to breathe, or if you're listening to the lungs, you can hear a wheeze throughout, that might be diagnostic. If you can hear a wheeze in one area, that's not always asthma. That could be a nasty infection in one area, or a kid who's inhaled a bead or something and it's stuck in one of their airways. Look at the shape of their chest. Have they got any deformed sternum or back? And you're looking for signs of rhinitis now. How do you look for signs of rhinitis? In a kid, you might have a little crest of red across the top of their nose, or a big streak of red across their cheek where they're constantly wiping their nose. In an adult, you'll see them, they've always got a hanky in the hand. They're looking, like they're going to sneeze every 2 minutes. Doesn't look good in a COVID environment, does it? So diagnostic testing, I know you guys probably aren't doing any spirometry at the moment, but it'll be back. So spirometry is there to assess airway function. So we're having a look to see how open those airways are, how fast that air can flow out. And we do pre and post bronchodilator testing to assess reversibility, so we can diagnose. We can use it in children from about 7 up, depends on the child, and depends on the adult. Some adults don't manage it at all. And just remember, just because somebody comes back with a normal lung function doesn't mean that they haven't got asthma. It might just mean that their asthma is well controlled at that time. Now, peak flows are no substitute. So peak flows are the little tube that you can breathe down and you can see how far they get it. They're no substitute for lung functions. Occasionally we use them if we're trying to see at home if their peak flow drops at night or at first thing in the morning. But we definitely do lung function anyway. And always adhere to COVID infection control guidelines. So up here in Queensland, we're using the viral filters. I don't think in Sydney you'll be doing spirometry at all at the moment. So other investigations, allergy testing, skin prick tests, they're really good because you can get about 20 different allergens, possible allergens, on one arm, which is great. Whereas if you send people off for a blood test, which is called a RAS test, to see specific RAS levels for, say, you patient's got cats or house dust mites, maybe an issue, or mold, we can only ask for 3 without the patient getting charged for the rest. So that kind of cuts down what you can ask for. As I said, challenge provocation testing is done at a lung function lab. You'll find that there's some in Sydney that will do them for your patients. And we only do them as a last resort if we can't see it on spirometry. Chest x-ray. Now, the National Asthma Council say it's only useful for differential diagnosis. We always do a chest x-ray for our patients because there's other things that you can see that you might not have noticed. They might have heart failure, and you can see their enlarged heart, and then you can send them off for an echo, or there's, you know, a lung tumor or something like that you wouldn't know if you were just playing about with their asthma. So we definitely encourage a chest x-ray. Now, asthma is more likely if the symptoms are recurrent or seasonal. So every spring they get sick. Worse at night or early in the morning. Now, if you think about COPD patients are fine during the night, usually sleep all night unless they're sick at the time. Whereas asthma patients, they might start coughing when they go to bed and cough all night and first thing in the morning, and they can get up and do things during the day okay. They might be triggered by exercise or irritants or allergies or viral infections like we've talked about before. And if you give them some short-acting beta agonists, so Ventolin or Bricanol, and they can get better quite quickly. Now, when you're talking to the patients, their symptoms might have begun in childhood. So a lot of patients that come to us maybe in their 40s and 50s say they've not had asthma at all in their life, but when you actually dig deeper, they talk about bronchitis as a child, and that bronchitis was probably asthma. So recurrent bronchitis in and out of hospital isn't likely to be just bronchitis. And if you're looking at their lung function, their FEV1 will be lower than predicted, so less than 80% without any other explanation. They might have raised eosinophils on their full blood count. That's why I said to you, get a full blood count, or raised IgE levels. It depends on what kind of asthma. So asthma is an umbrella term for different kinds of diseases, different kinds of asthma. So we've got to phenotype them, and some asthma patients are driven by high eosinophil levels and some by IgE levels. And it's important to know that because treatment later on will depend on what those levels are. So alternative diagnosis I've kind of alluded to already. Not all that wheezes and coughs is asthma. And cough can be predominant, but it's very rarely to be the only asthma symptom. Allergic rhinitis, bronchiectasis, which is like when you've had infections in your airways and they've been widened. Bronchiectasis just means widening of the airways, and they produce a lot of phlegm. So when you're talking to them and they cough up half a cupful of phlegm every day, not likely to be asthma, more likely to be bronchiectasis. COPD, so chronic obstructive pulmonary disease. Hyperventilation or dysfunctional breathing. Dysfunctional breathing is quite common. Vocal cord dysfunction is more common than you think as well. And that's where your vocal cords actually snap shut when you're trying to breathe in. And that doesn't respond to inhalers or steroids. Inhaled foreign body, as I said, if you hear a wheeze over one area, it might be something like an inhaled foreign body. Chronic heart failure, so CCF, might present as shortness of breath and a cough. Pulmonary hypertension, shortness of breath. Obesity, they're just breathless because they are big. I've got a lady who's 200 kilos at the moment. She has got severe asthma, but it's quite hard to differentiate between just huff and puff because of her weight, or her asthma is out of control. It's really difficult. Reflux is a comorbid condition that can sound a bit like asthma, so they might get a cough from that. Postnasal drips, the same. Enlarged thyroid, so obviously if your thyroid's enlarged, it might be pressing on your trachea and causing you to cough. Side effects of medications. What kind of medications make you cough? Anybody want to hazard a guess? Stick it in the Q&A or let us know. I'm going to just sit there and say nothing. What tablets can make you cough? Anybody?
Oh, hold on, here's one. What's this?
Oh, somebody's awake.
ACE inhibitors.
Yes, that's the very one. Definitely. So if they're on ACE inhibitors, it might be worth just trying to swap them from an ACE inhibitor to another antihypertensive, and if the cough goes away, that's what it was. Exercise-induced respiratory symptoms, so you've just got normal huff and puff, they're unfit. So any questions so far?
No, it looks like everybody's happy so far.
Happy or sleeping, one of the two.
Happy, I
Right.
think.
Oh, happy, we'll go with happy. So how do we manage these people? So we know it's a chronic condition. It needs ongoing care. It's not just about treating that asthma attack that walks in the door in front of you. We need to actually teach these people how to manage their condition themselves, because you can't be there with them all the time. Although some of my patients think I just live to answer my mobile phone, because they'll phone and text me all sorts of hours. Asthma action plans are very important, as I said before. We need to be considering, when you're doing management principles, other lifestyle issues, so getting them to quit smoking, weight loss, that kind of thing, exercise. So our pulmonary rehab program here will take patients with asthma, especially if they've been in hospital, to try and get them fitter so they can cope with their asthma better. Medical management obviously is very important, and managing their comorbidities is extremely important. So smoking cessation, keep doing it every time they come in. You ready to quit yet? Eliminate passive exposure to cigarette smoke. That is very hard when you've got a little kid who's got asthma and the mum and dad both smoke. I've had such a hard time with some of the parents, because they're like, well, that little 4-year-old or a 5-year-old, well, we don't smoke in the house, we smoke outside. I'm like, well, where does your 4-year-old go when you go outside to have a cigarette? I bet you a fiver they're outside with the mum and dad who's having a cigarette. The other thing they don't realise is when they come back in, if they are outside and the kid's inside, they bring that in with them on their clothes and in their hair, and the little kids' lungs are really sensitive, and it can trigger it off just breathing in the smoke that's stuck to their clothes. So it can be quite hard to get adults to think that that is affecting their child. They just want a magic cure. Identifying triggers. As I said, we can go through what they think is happening. We can find out what they're allergic to by skin prick testing or RAS testing. Getting them to eat well, ideal body weight, exercise, as we spoke about before. Stress management. Now, we used to have a psychologist at our severe asthma clinic, because a lot of our patients have a lot of anxiety and stress, and that can make their asthma symptoms worse. Yeah, not being able to breathe is very stressful in itself, isn't it? So this is a very busy slide. You don't need to worry, I'm going to break it up for you in a minute anyway, but you can see there's number 1, 2, 3, 4, 5. Number 1 being very few patients that only need just Ventolin or Bricanil. We don't recommend that for most patients, okay? The only few patients would be somebody who has very few flare-ups. They only need Ventolin maybe once every couple of months or something. Whereas number 2 would be most patients where they need something to control their asthma, and that wouldn't be anything too strong. So that would be just a mild, a low dose inhaled corticosteroid, or this new thing that's come in, which is Symbicort or budesonide formoterol, low dose as needed, so they can use it PRN. Still need a script for it, can't buy it over the counter, but instead of using Ventolin or Bricanil, they take a dose of Symbicort or the equivalent of Symbicort. Only some patients need a regular daily ICS LABA, which is the combination, you know, like Symbicort, Seretide, Breo, there's lots, Glutiform. So only some of them need a low dose of that, whereas very, very few need a high dose, medium to high dose ICS LABA. So you can see probably what happens in general practice. Well, maybe I'll get skew data, but what we see coming into the hospital or coming to our clinic is everybody's on a huge dose of Seretide or Symbicort, which they're not taking regularly anyway. So we do, you can see the arrows going up the side there. We can escalate up if patient's control is not good, but if patient's control is really good, we can pop it back down to the lowest dose possible to maintain control. At the top is number 5, and that's the specialised treatment. So all the biologic MABs, so Xolair and Fasenra and Nucala, and there's a new one which is called, I've only given it once, come to me in a minute, I'll think about that one. So this is it broken down. As I said, number one is for your asthma patients who only need a Ventolin, which you see quite a lot of patients are just puffing on Ventolin all day, every day. Most patients will need some kind of low dose inhaled steroid. So we're talking about Pulmicort, Flixotide. I'm trying to think, QVAR, anything like that. Or, as I said, the new thing is budesonide formoterol low dose as required, so PRN. And then most patients would need a regular daily dose of ICS, so low dose ICS or that budesonide formoterol. Now, step-by-step management, as I said, you don't need to start at the bottom and work up. You can start anywhere and get the right level of preventive medication for the patient appropriate to their severities. We're not treating the asthma attack that's in front of us. We're treating what is happening at home. So how often do they use their Ventolin in the last couple of weeks? How often are they getting up during the night in the last couple of weeks? Think about what's actually happening. So most people need to be on preventive medication. Step the preventive medication up and down as needed as per the guidelines. And the goal is to decrease the treatment to the least medication necessary to maintain good asthma control. What we sometimes do in the severe asthma clinic is get them on the highest dose and then work our way down and see where we can stop it. So we might have them on the highest dose and then cut it down a little bit and make sure that their asthma control stays the same, and then cut it down a little bit and make sure it's still good. And you need to consider a respiratory specialist referral if you're not getting any response to treatment. All right, and all patients need some kind of reliever therapy. It doesn't have to be Briconil or Ventolin, it can be the Symbicort equivalent. And all should have a written asthma action plan. This is what's meant by high, medium, and low dose ICS. So it depends on the drug, what sounds like high or low, because it can be a bit confusing. So the new fluticasone furoate, which is in Brior, and Nuti is just the fluticasone on its own. A low dose is 50 and a high dose is 200, whereas fluticasone propionate, which is in Seretide, or you've got Flixotide there, the low dose is 100 to 200 and the high dose is more than 500. So it's totally different on each drug, okay? Now, this is all the inhalers at the moment in Australia. There's a few new ones coming out in the next few weeks, which will confuse everybody again. So they're set out with short-acting beta agonists on the top left there, short-acting muscarinic agents, so Atrovent in the middle, and the tablets that we have. So Montelukast or Singulair is the other name for that. ICS preventers, all that's available there. LABA medication, so long-acting beta agonists, so those long-acting Ventolin type drugs, Oxys, Ceravent, Umbres, and then you've got the combinations that are available. Fostair is probably the newest one, which is beclomethasone and formoterol. That's probably the newest inhaler on the market. It's two older drugs that's in there. There's nothing. So beclomethasone is in QVAR, it's beclomethasone. And formoterol is in Symbicort. LAMA medications are long-acting muscarinic agents, so your Spiriva, Vitara, Zincruz, they're all there. And then you've got the long-acting muscarinic agents and the LABA combinations. So Ultibro, Anora, Spialto, and Brimica, they're only for COPD. And Trelegy there at the bottom, ICS LABA LAMA, and it's only for COPD as well at the moment. So just to recap, confirm your diagnosis when you're managing asthma, assess their asthma control, recent asthma control and risk factors. So if you've got a patient who has been in ICU twice in the last year, you're not going to muck about with them saying, yeah, no, I don't have any symptoms. You would really need them on a preventer. Manage the comorbid conditions, have regular reviews where you approach the use of a preventer, so up and down as need be. Provide written information and some skills and tools to manage their asthma. So that written action plan is very important. Using the correct use of medication, so inhaler techniques, when to use them. So if you're on Symbicort, is it used twice a day, not once a day? It's amazing how many people come to us and they've got poor asthma control, and when you ask them, they use their Symbicort twice a week or once a day, and it's not the correct regime. You need to give them information about triggers, possible triggers, support and maximise medication adherence. Most asthmatics, when they get well, stop the preventer because they think you've cured them. Advice about cigarette smoke, healthy eating, physical activity, healthy weight, immunisation. So there's where flu vaccines and COVID vaccines would come in there. So what is good asthma control? Now, this would shock quite a lot of asthma patients. Asthma control involves assessing the symptom pattern over the last 4 weeks, not just about the asthma attack that's in front of you, and assess the risk factors for future adverse events. So if they've had an ICU admission, they're more likely to have another ICU admission if we don't control it. And good asthma control would be having daytime symptoms equivalent to about 2 days a week or less, and they use a reliever the same 2 days a week or less per week. And we don't count before exercise because that's kind of a preemptive thing. So say they take their Ventolin 10 minutes before they go to the gym, we don't count that in that number. No limitation of activities, they can do everything they want. So when patients say, yeah, I'm fine, do ask them, do they walk up the stairs, or if they had to run for the bus, what would happen? I had one guy yesterday, I asked him, he says, oh no, I'm fine. I says, well, what if I got you to run for the bus? He said, I wouldn't run for the bus, I'd wait for the next one because I would have an asthma attack. So he's not fine, he's avoiding things. And they have no symptoms during the night or waking in the morning. So that's in the last 4 weeks. So how many patients come into that good control? What we see, very few. Partial control would be having 1 or 2 of the following, so daytime symptoms, needing their Ventolin or Aboriginal more than 2 days a week, having limitations of activities, any symptoms during the night or waking. So if they say they wake up 1 night a week, needing some Ventolin, or the first thing in the morning they need some Ventolin, that would be partial control. Poor control would be 3 or more of those things. If they're like waking up 2 or 3 nights a week, they're limited at doing their activities, they need the Ventolin every day, that would be poor control. And the reasons for poor asthma control, it's usually because the inhaler technique's shocking, all the medicine's just coming out the sides, they're not using it appropriately, their adherence is bad. A lot of patients will just start their preventer when they get sick, they don't take it all the time, and it takes about 3 weeks for an ICS to start working properly. They're on the wrong dose, they're on too low a dose, or they're just relying on their Ventolin and not taking any preventer, or they've got medication interaction. So as I said before, if it started on beta blockers, that can be an issue, or they've got really uncontrolled trigger exposure. Something's happening at work, they've got exposure to chemicals, and they're smoking like a trooper, allergic to cats, and just started working in the, I don't know, the RSPCA or something with all the cats. If they don't have a written action plan, they're more likely to have poorer asthma control because they don't know what to do. It's not written in front of them. If they don't have regular reviews, they're more likely to have poor control. If they don't understand why they're taking a preventer, they're more likely to have poor control. If they've got really severe asthma, they're going to have poor control and they need to follow up at hospital. And if it's not asthma, you're going to get poor asthma control because it's not asthma you're treating. And always consider referring them off to the pharmacy for a medication management review just to see if there's anything that can be causing their poor asthma control. Sorry, I've got a really itchy nose. I don't know what that means. Right, exploring patients' perceptions and guiding self-management. I'm going to tell you a story about one of my patients. She'd been in an ICU, and while she was in ICU, because I think she was intubated for about a month, she was quite heavy, and she lost about 30 kilos. So when she came back to see us in clinic a few weeks later, I asked her, how's your asthma? She said, great, it's really good. But when you actually asked her properly how many puffs of Ventolin was she using in a day, she would maybe 10, 12 puffs of Ventolin a day. Now I said, and that's every day. And I said to you, per control would be that. But because she used to use her Ventolin about 20 times a day, she thought she was wonderful. So people's perceptions are varied depending on what they've been through, what they see at home, what their perceptions are of what is asthma. You need to personalize written action plans, because obviously that person I can't write. When you use your Ventolin, you need to use your Ventolin more than twice a day, then I need you to do such and such, because if she uses Ventolin 10 times a day every day, and she's already on a preventer and she's on a long-acting muscarinic agent, we're not getting her to start prednisolone every day of the week, you know, so you have to have a really personalized written action plan, okay? And every consultation that you have with a patient is an opportunity to review and reinforce what you've taught them already. You'd be surprised how many of our severe asthma patients would come to us for years, stop using their preventer, or stop using their spacer, just because somebody told them spacers are just for children, or preventers cause you to gain weight, something daft like that, and they'll just listen to that person next door rather than listening to you. So you need to always be looking at what's happening at home. And education is definitely not a single visit thing. It's a process that you need to keep going through every time. So just asking the right questions. As I said, 78% of Australian asthma patients believe they are well controlled. 13% of Australian asthma patients are well controlled. So there's a huge gap in perception versus reality there, isn't there? 58% of patients use their reliever at least twice a day. So well-controlled asthma is using your reliever less than twice a week. So there's 58% that are definitely not controlled. Don't just ask, how's your asthma? Because they'll say fine. Some of my asthma patients won't even phone me when their asthma is bad. They'll text me, and I know because they're texting me that their asthma is bad, and I'll phone them just to hear what's actually happening, because they can't speak in a sentence and they don't really want to go to hospital. So you need to ask them, how many times have you used your reliever puffer? With my patients, how many times have they used it in the last hour? So it depends on your patient. How many times has your asthma woken you up at night? How many times have you been short of breath? Are you able to run for the bus? You know, that kind of thing. Make it personalised. Now, asthma review, you need a regular review every 3 to 6 months when they're stable and well controlled. Before allergy season, especially those ones with the allergic rhinitis, you need to have a review just to make sure that they're taking the preventer and everything's okay. If you increase the dose to get control, you need to have a review about 4 weeks later just to make sure you've got the right dose. Same when you're decreasing the dose. You don't want to just decrease it and then send them off on their way. You need to see them again at 4 to 6 weeks. If they've been in a hospital, within 2 to 3 days, and then again 4 weeks later at the most. And there's validated questionnaires that you can use to assess their recent asthma control. They're in the resources for the Asthma Handbook, so you can print them off. Where I worked in Scotland, I worked in GP land in Scotland, and we used to just leave them for the patients to fill out before they came into their consult, so they don't have to do it in front of you. Perform spirometry to monitor lung function in response to treatment, obviously COVID allowing. This is about treatment, long-term management, short-term treatment, and emergency bystander. So we'll go to emergency bystander. So if you're down the park and somebody has an asthma attack, you do the asthma first aid plan, and I'll go through that with you. But your asthma patients, they need an asthma management plan. So Included in that would be their written action plan, management education goals, adherence, triggers, diet, medications, and so they can have a GP/MP and a team care arrangement, and that will reduce symptoms, improve lung function, reduce flare-ups, and then you might get some asthma well controlled. Short term, they might be well controlled and then all of a sudden get a viral infection or by a cat that they're allergic to. Their asthma might get worse. The written action plan comes in here so that they know what to do when they get sick, and they can prevent progression to a severe exacerbation. Written action plans, they're there to improve outcomes. So people, if they have a written action plan, they might miss school or work less often, and they might wake up less at night, and improved symptom scores. Helps people recognise worsening asthma symptoms and gives them something they can do to adjust their medication to help. So it might tell them to increase their Ventolin use to, say, 12 puffs every 4 hours, start their prednisolone, see your GP, when to phone an ambulance. And they must be personalised, be in a language that the patient understands. So if you've got somebody whose English is the second language, there is plenty on the market for different ethnicities. And it has to give some advice of modification of treatment according to symptoms, either increasing Ventolin or starting prednisolone, whatever. Contain emergency steps, so what to do in an emergency, and should have the contact details of who's written the plan, so the GP practice phone number. On mine, it's obviously got our phone number, and there's some resources there for guidance on the Asthma Handbook. This is some of the action plans. So the one on your left, a nice colourful one, that's the one we use in our practice, the National Asthma Council one. On the front is what they do. So when they're well, this is what medication they use when they're starting to get sick. So say they've got a cold or they've noticed that using their blue puffer more often, what to do then. Some of our severe asthma patients will have starting prednisolone there. So if they're increased symptoms, they might start their prednisolone there. Other patients, if they don't get too sick, they might wait till their symptoms are worse. They're using the blue puffer every 3 hours, and then they might start the prednisolone there. There's some through ZMed, Medical Director. There's all sorts of different ones that you can use. It's up to you guys which ones you want to use in your practice. There's targeted ones as well. So on your right is the Symbicort maintenance and reliever therapy action plan. So that's when they don't really use Ventolin. You need to know how many extra dose of Symbicort they can have in a day. And it's called March now for some reason. They've taken out the Symbicort part of it, because I think you can use, well, there might be other medications coming out that they can use, like smart therapy, where they use the preventer is the same as the reliever, and they use that twice a day plus extra during the day. And there's culturally appropriate ones for Indigenous Australians, the short wind action plan. So remember I said, when you see somebody down the street or in the park and they're having an asthma attack, and you're treating them as a bystander, as a member of the community rather than in your general practice, what you would do is the same for adults and children, is sit them down, try and get them to relax, give 4 puffs of a short-acting beta-agonist via spacer, so Ventolin, salbutamol. Take 4 breaths with each puff, so 1 press, 4 breaths, 1 press, 4 breaths, 1 press, 4 breaths, 1 press, 4 breaths. Wait 4 minutes. You don't have a clock, don't worry, just wait a few minutes. Still no better, you carry on with steps 1 to 3, so another 4 puffs, and wait another 4 minutes. If there's still no better, you phone an ambulance and you keep going 4 breaths, 4 minutes, 4 breaths, 4 minutes until help arrives. A lot of patients look at me and go, wow, I'll overdose on Ventolin, that's very unlikely. If they get better after the first 4 puffs, that's fine, you can stop and get them to go and see somebody about their asthma. But if not, you keep going till the ambulance arrives. So warning signs you're having an asthma flare-up. Does anybody want to ask any questions before we go into kind of having asthma attacks?
We've got one, Rhona, on is there any preventer that doesn't have cortisone in it? And there's a question mark about osteoporosis and as being a side effect.
Okay. Preventer inhalers don't really cause osteoporosis. It's the prednisolone, the steroid tablets that will cause that if we're not monitoring to see what the bone scans are doing. There is one called, well, there's two, Intal and Tylade, but how long have I been doing this job? 20 odd years, more than that. They don't really work very well. You're better with a steroid inhaler. In children, you can use Singulair, which is a tablet for asthma on its own without having a steroid inhaler. But osteoporosis is more a risk if they're on lots of doses of prednisolone. Does that help? No response?
Well, it's answered the question. Thank you.
Okay. So warning signs you're having an asthma flare-up. More symptoms than normal. You're wheezy, coughing, more short of breath than normal, needing your blue puffer more than 3 times a week, waking at night with asthma. Asthma is interfering with the exercise. If you're needing your reliever every 3 hours and it's interfering with normal activities, they should refer to their action plan and see where they go from there. So management in GP practice, when somebody comes in and they are saying they're having an asthma attack, I don't know what happens down there. Do they get COVID swab before they can come in? I don't know, I'm not sure. It's a bit worrying, isn't it? I think all asthma patients, because they cough, will probably end up in ED at the moment, but COVID will go, hopefully soon. Anyway, so management in general practice, so you do a primary assessment to see whether they've got mild, moderate, severe or life-threatening symptoms, and I'll go through what all of them are in a minute. Some pulse oximetry, see what their oxygen levels are doing. You're going to give bronchodilators, do a secondary assessment, work out what management you're going to do, and then work out what follow-up needs to happen afterwards. So the primary assessment. So mild and moderate, they can walk in, talk in a whole sentence with one breath. If it's a young child, they can move around and speak in phrases or babble away. And their oxygen sats are normal. Severe would be using any accessory muscles, having a tracheal tug, recession of their subcostal areas, abnormal breathing, unable to complete a sentence in one breath due to shortness of breath. So they can, I'm doing okay, thank you. So they're constantly having to take a breath in between words. They're obviously in respiratory distress and their oxygen stats are starting to fall. Life-threatening would be starting to get reduced consciousness, or they'll collapse. They're exhausted, they're blue, they're not making much effort. And when you listen to their lungs, they've got very soft breath sounds or absent breath sounds. So a silent chest, and their oxygen stats have fallen. So management of mild to moderate flare-up in your practice, salbutamol via a puffer and spacer for adults up to 12 puffs, and repeat at 20 to 30 minutes in the first hour or sooner if needed. Monitor and maintain oxygen saturation, so you want the oxygen levels over 95 if possible. Observe and monitor for at least 3 hours. If they don't get better or there's no response, you call an ambulance and you keep giving them the salbutamol via the spacer till the ambulance arrives. We're only using nebulized salbutamol if the patient can't breathe through a spacer, and that's not going to happen very often in COVID times because you don't want to be nebulizing anybody unless you've got full PPE on. Consider commencing their oral steroids within that first hour. So quite often we'll start the 150 milligrams of pred as soon as we notice that they're having a flare up. When is it an emergency? If they're in severe respiratory distress, they're using accessory muscles, they can't talk in a full sentence, their oxygen sats are less than 90, their reliever response is not immediate, so they don't get they come back to normal straight away, or it's not sustained for that 3 hours. If they start to get worse, even though you're giving them treatment, or if it says on their asthma action plan they need urgent medical treatment, so they might have been to the specialist because they've had a couple of ICU admissions, it'll probably say on there, as soon as they start to get worse, they need to go to hospital. Because what we don't want is them intubated in ICU again. So call an ambulance. This is a hugely busy slide, but this is in your guidelines. So the Australia Asthma guidelines, and there's what to do immediately, within minutes, within an hour, after 1 hour check, and then there's for children 1 to 5, children 6 to 11, and then adults and adolescents, and we'll go through that because it's cut down a little bit in the next slide. So life-threatening episode of asthma. So you've got somebody in front of you who can't speak in a sentence, they're using accessory muscles, their SATs have dropped. You want to give them some Ventolin through a nebulizer if you can, safely. As I said, if they're coughing, you don't know if they've got anything else. You would probably need to have them on full PPE, you on full PPE and nobody else in the room at the time. So for an adult 6 years and over, they can have 2 5-milligram nebules, one after the other. Maintain their oxygen saturations and try and aim for 93 to 95. You're going to get them to emergency department as soon as possible. If there's poor response to Ventolin, you can add in ipratropium bromide, which is Atrovent, 500 micrograms. If you know improvement with that, you can add in IV magnesium sulfate, which will help try and control this. When they start to improve, their dyspnea starts to improve, you can consider changing them to an MDI and spacer then, or cut their nebulizer down to every 20 minutes while you're waiting for the ambulance. If they're having a flare up, you want to review them like at least a couple of days later, and you want to have a comprehensive review within a couple of weeks. So what went wrong? What happened in that flare up? What happened before? What triggered it? Because you want to try and avoid it in the future. Want to have a look at their medication and what were they actually doing with it? Were they actually taking any preventer? Were just relying on Ventolin all the time? Some of the patients we used to have some samples, and some of our patients, poor souls, couldn't afford a reliever. Even the $6, whatever it is, that if they've got a pension card, they still couldn't afford that. So it's it's that kind of thing you're looking for. Do they have the reliever available? Also check the reliever's in date. If they've not had an asthma attack for a long time and then all of a sudden they're starting to take Ventolin, and I've had a patient whose Ventolin was like 3 years out of date and they didn't realise. Check-in device technique again there. Written action plan, review self-management and action plan use. So did they have an action plan? Did they start it when they should have? Why not? Or if they didn't have a management plan, then you need to get one. Spirometry if you can do it. And review and modify the treatment plan if needed. Now, asthma and telehealth. We use a lot of telehealth in our practice. So I might see patient once and then see them via telehealth, where they can see me, I can see them. And it's a great way to engage with patients. They can show me how they're using their puffers. They can show me their action plan. They're at home, so they're more they're more comfortable speaking to you. And you can use it like an asthma score check, so you can send them it by messenger or whatever beforehand, so that they can have it filled out for you and you know what's happening. You can look at their action plan, make sure they've got enough medication, especially the reliever, and you can use the video conferencing for device techniques. COVID-19 has scuppered everybody's plans, hasn't it? There is some help with updates and things on the Asthma Handbook regarding COVID-19 and what to do with asthma patients. making sure everybody has a written action plan is really helpful, because as I said before, if you've got a cough, trying to make an appointment with a GP is not going to happen until they have a COVID negative test, which might be 24 hours later, which might be too late. So knowing that they can go to ED, it's all right to go to ED, might be the option. Infection control recommendations for spirometry you need to follow. As I said, they're in that asthma handbook. We use the filters and wipe down everything after every use, and don't sit in front of the patient as they're blowing either. And they need to keep taking their current medication, so their preventers are very important. If they're not taking them, then they might be at risk. Oral steroids are not for using every day, they're just for flare-ups. So patients do some weird and wonderful things, and things like COVID times, start taking the steroids just in case they catch COVID, which isn't a good idea. So that's what happened with all the Ventolin last year. A lot of people who don't even have asthma went and bought Ventolin just in case they caught COVID, because they thought that might help, which is not going to. Avoid using nebulizers. Puffer and spacer is much preferred, and anyway, puffer and spacer is just as good as a nebulizer. So if they can breathe in and out, they can use a puffer and spacer. Advise the patients not to share any medications, especially spacers, between family members, and always have their action plan and the reliever handy. There is some resources that you can use to download stuff or have videos showing people how to use a puffer and spacer. Obviously, this talk is not developed by myself. There's the people who've been involved. Now there's a QR code on the screen just now. If you want to scan the QR code, the evaluation will pop up. If not, when you log off from this, evaluation will pop up. Please fill it out, because the National Asthma Council get their funding from the government to provide this education free to you. If we don't put in enough evaluations, then the government will stop the funding. And we also, if we're dishing out education and we don't get any feedback, then this education might not be the best education for you. So we need to tailor the sessions to your needs. Right, any questions?
Got a couple. So going back to medication, a question about Singulair for adults, particularly those with allergic rhinitis.
Yep, and yep. We use it a lot. If you pick your patients, or those really allergic ones with an allergic rhinitis and whatnot, yeah, it can work really well. Just have to be aware that some people get some mental health issues on Singulair, but they know straight away, and as soon as they stop it, they'll go away. It's not something that lingers.
What dose of IV magnesium is required?
It's in the guidelines. I don't know offhand. It'll be in the guidelines, and you can print that big sheet off. I don't know if it says. Hang on, I'll go back and see. You can print that big sheet off and put it on the back of your door. Hang on, get my glasses on. No, I can't read it. Sorry, it's too small. But it does say in the guideline, when you get to this page, acute asthma in adults, if you just Google that on the search engine in the asthma handbook, it'll or put in IV magnesium in acute asthma, it'll come up with the dose there.
And somebody's saying they cannot actually find how to download the questionnaires in the handbook. Any hints?
Oh, no, try the drug reps though, they have loads of them. We don't actually use the ones that the National Asthma Council uses. We use the Juniper questionnaire, which is the one that if you're going on to biologics that they use. We're not allowed to share because the lady Juniper who developed them in the UK has complete control over that. But the drug reps will have them for the biologics, you can ask them. But they'll also have the one that's in the National Asthma Council downloadables. If not, try phoning the National Asthma Council or emailing them and see if they can send you a copy.
And can I just ask, Rhona, are you happy for us to distribute these slides to the participants?
Yeah, I think the National Asthma Council have agreed, haven't they?
I'll check with Robbie.
Yeah, I think they have. I think they said that the recording can be up for 4 weeks. Yeah, it's not up to me, it's up to them. So these are the other webinar topics that I spoke about earlier on. I don't know whether you guys are doing any of the other topics at a later date, because usually this one comes first. Do you know, Sandra? I don't know.
Robbie said she was back. She doesn't seem to be answering. Well, that's all the questions we have on the Q&A.
Okay, cool.
Couple of thank you very muches for.
No, you're very welcome. I hope it wasn't too fast. I am Scottish and I can't really help speaking really fast. It's just the way I am. But if there's any questions, they can be forwarded on to me. You've got my email, Sandra, haven't you? Or Robbie has?
Robbie will.
Yeah.
Can I just ask, am I screen sharing?
You can if you want.
No, am I?
No, not at the moment.
Okay. Sorry. Just let me go back. Put my screen up. Just go all the way through to the end. Oh, oops, too far. So thank you, Rhona. That was absolutely fantastic. Thank you, everybody, for participating this evening. And just repeating, both for Rhona and for Sydney North Health Network, please complete those evaluations. That information is really valuable to us to tailor the education to your needs. So thank you, everybody, and good night.
Thanks, guys. Thank you for staying awake. Bye.